Actually, my work was more on epidemiologic investigation side than rather clinical side, but happy to share. The second point would be all my experience based on the joint research project between Chiang Mai University and Johns Hopkins Public Health School. That's about 10 years ago. So the data may be a little bit old, but the situation is still similar among the young substance abuse user. But as Vipaporn mentioned, that it dynamic. So keep in mind that the situation may add more complexity now than when the research finished. But 20 years in addiction field, we still see adolescent as the target population because the onset of all substance use, not only substance use but addiction like gaming, internet, and things, the onset occur during adolescence. This because biologically the brain development occur from the back to the front. So the frontal lobe, which their function is dealing with the cognitive function, the inhibitory control, the decision making, seem to be slowly developed compared to the other part which dealing with emotion and so on. So you will see adolescent has more emotion and difficulty in controlling their desire and emotion than adult. So that's quite a common explanation. With substance, actually, it adds more because many substances can trigger dopamine release in the brain, and rapid dopamine release have an action at the rewarding system in the brain, and it provides feeling of satisfaction, very sudden satisfaction in the brain, and you remember that. You probably remember the good things about the food that you taste, and whenever you smell it or you find it, you can recall that experience, and you would love to repeat that again. So that's a basic principle of repeated behavior and become addicted later on. I won't get down into details. So not only substance, but sex, for example, can also provide a high rapid shooting of dopamine, and people can addicted to sex as well. But adult can control how to have a proper sexual frequency and desire and behavior. So we try to explore about methamphetamine use among young population in Chiang Mai. About 1,000 of young methamphetamine users who use methamphetamine 3 times at least in the last 3 months, age 18 to 25. We cannot convince the ethical committee that we should focus from 15 forward, but we failed to get that. So we got 18 to 25, and you can see that that's too late for understanding the situation because majority of them actually use methamphetamine around before 18, obviously, and majority of them inhale methamphetamine, they burn it and inhale. They have multiple sex partners in this population, and the age of first sex around 13 to 14 years on average. We study at baseline the sexually transmitted infection and find that we have high STI prevalence, which we can expect for among these young methamphetamine users. We target chlamydia and Neisseria gonorrhoeae, and you can see that this is this for prevalence for female methamphetamine user. This is for male. and this is gonorrhoeae. And this is the reference population. And you can see that among this population, they have high prevalence of STI. And noted that female methamphetamine user actually get higher prevalence than male. We analyzed the factor related. We found that more than 20 years of age, that means collectively they have many partners for that risk, and more than 2 heterosexual partners in the past year. For women, methamphetamine user at younger age would be at higher risk. Men would have both sex and drug network in their daily life, would have a higher risk of getting sexually transmitted infection. We follow them up for 12 months, and we find that among this group, they have reinfection, 13% of them. The risk factor would be incarceration and having casual sex partner. For women, having two or more heterosexual sex partners. For men, have a frequency of drunkenness, of drinking and drunk. We have only around less than 1% HIV positive, so we are not able to analyze anything about related to HIV yet. We do have a small study among ecstasy user in Chiang Mai city, and to understand the complexity of using stimulant among young population. And you can see that they have free sex network, they engage in new sexual contacts. Some who use drugs or substance, they connected to dealers, and some may be able to provide like a small dealers, connecting to how to get access to substance use. Obviously, the dynamic of drug situation has changed with the online service. Now they can buy everything online. They don't need to go and see people to get drugs. When we get down into the qualitative details of try to understand about the perception of substance use, especially the methamphetamine, which is the most common one in Thailand. Males provided that methamphetamine increased their sexual desire, sense of sexual pleasures, and the ability to have sex for a longer duration of time. For female, similarly, methamphetamine enhance their sexual desires, and they can have more sexual energy and increase sexual sensation. But not all of them that we study have answer along this line. You can see that we only have 13 out of 48 that have this perception and feeling and experience. But the others actually has either no effect or even decreasing their sexual desires. Those one would be the one who use methamphetamine more frequent and longer, and they said they lost their sexual desires after they are heavy user. And very few users reported using condoms. So in conclusion, why ATS use or methamphetamine use among this population linked to sexual risk behavior and STI, they have sex on drugs when they use methamphetamine. When they don't use it alone, they use with different sex. They tend to have a new sexual risk coming in, and they use among new friends. They drink alcohol and then having sex. Some have sex for drugs or earning money, and they not use condom very much, less than 30%. For another finding which may link to how to approach them would be they also, the longer duration they use methamphetamine, the heavier they drink alcohol. So you are not dealing with just one substance. When you find adolescents who use substance, they not focus just only illicit substance, but they also use licit substance. So try to do more comprehensive evaluation on substance use among adolescents who have a problem. After a while, I learned more about the complex multiple psychosocial risk factors and the new word we call psychosocial syndemics. And many findings conclude that harmful social conditions, like various examples of case study that presented earlier, you can see that there are many harmful social conditions and early life trauma or stress that considered to be a great psychosocial risk factor, and violence and depression. This also lead to HIV risk. There's a study that conclude on various factors, psychosocial factors or conditions like depression, stimulant use, mixed together or stand alone, and polydrug use, heavy alcohol use. They all have a synergistic effect on HIV risk. A study at MSM cohort study in Bangkok reported the same finding, that the number of psychosocial syndemics can predict the incidence of HIV infection among MSM here in Bangkok. And you can see that this is the survival curve, and more psychosocial syndemics factor would increase the risk of HIV infection all along. And when look at the HIV treatment outcomes, many reports together suggest that substance use, early life trauma, and depression actually are three major psychosocial factors among the others in increasing risk of, not only increasing risk of HIV infection, but also act as barriers to accessing treatment because of various psychosocial conditions, and also associate with suboptimal adherence, which you may see from the previous case study, associated with greater HIV-related morbidity and mortality. Another study reported that alcohol use, depression, and sexual risks are associated with worse viral suppression in multi-center AIDS cohort studies. And you can see that compare no syndemic factors with three syndemic factors, you can see that those response relationship on that. In Chiang Mai, we try to see how we can help our young methamphetamine user. Obviously, just say no probably won't be able to help them much. We did randomized control trial by using network-oriented peer education intervention. We organized in a group having index participants and their network member, and we organized 6 sessions of harm reduction compared to 6 sessions of life skill training, which is a standard training recommended by UNODC. This is the details of peer-based network-oriented education, introduction of peer mentor, how they can help their friend understand the friend and try to apply principle of harm reduction to help their friend. What is the effect of methamphetamine use on individual? What would be the interaction between methamphetamine and social influence? Methamphetamine on sex and other risk behavior, and try to expose them to family community issues and have them engage in some community activities to allow them to have a real interaction with the communities. For the life skill training, it would be standard life skill, but we add on sexually infectious disease ethically because we know that they are high-risk population. And after following up for 1 year with retention rate about 85%, you can see that we are able to reduce methamphetamine use among both groups, actually, both index participant and also their network member. That means you can apply whatever that dealing with psychosocial issues to this population. Actually, it can lead to behavioral change. Not 100%, but actually it has a good trend on that. We try to provide to put attention control into the design, and you can see that actually with similar attention to these kids, they do believe us and they change behavior. So attention may be a key. You provide non-judgmental approach to them, connect with them, and provide a sincere approach to help them. I think that would work. And we try to look at the condom use, and you can see that among the intervention group, which focus on harm reduction, we have a little bit higher rate of condom use after a year. Unanticipated impact of our intervention, we find that our intervention actually focus on harm reduction, but also can reduce the depression condition among this population as well. So that's go well with the previous and the other report, and the previous study suggests that it's a complex of multi-layer factors among this population. So in conclusion, adolescents are prone to substance abuse because of biological and also psychosocial risk factors, and multiple psychosocial factors interplay into multi-layers of complex risks of HIV infection and adherence and failure of care. So if you are able to explore, evaluate them, focus on early life traumatic stress, substance use, and depression, that may give better comprehensive approach to them. Thank you very much.
Thank you so much. Do you have questions? Any comments about substance abuse? Because it adds more complicated, to take care of our adolescent, even adolescent without HIV. Yes. Oh, you first.
In your study, did you address the confounding factor like level education or income or something? Yeah, the background of the study participants.
Yeah, we adjust for that, but because the age range is so narrow, so we don't have different level of education and income. We adjust for income, and that's the result of multiple variation adjustment. And actually, at the beginning, we believe that methamphetamine and sexual transmitted infection is dose response. That means the people who take more will have more risk. But actually it proved that we were wrong. If you take more, actually you decrease decrease the sexual desire and decrease sexual frequencies and so on. Yeah. Yeah.
I have a question about delivery of the intervention. So I think quite clear in your research, it showed that we have to give attention to early life stresses and trauma. In your opinion, do you think that can be delivered by HIV healthcare providers, or do we need to refer them to specialists like you to deliver this care?
First, I'm not that specialist. It's just fine that, but we understand the situation. I think you also link with psychiatrists already in your program. I think psychiatrists know how to further evaluate the risk, the trauma during early life actually created post-traumatic stress events, and they have a variety of ways to approach that. So the response to your question would be, yes, if you have psychiatrists or psychologists, psychiatrists may be too burden to them. Psychologists can relieve, because another study on National Household Survey, we find that not all substance users have high risk. Only 10% of them that would need attention. So if you have a nurse who train on this, psychologists who understand about HIV and adolescent, I think that would do. To do this study, we opened up the drop-in center, because by that time the law enforcement environment is still very strong. So at drop-in center, the police allow us to operate at the research protocol, and within the safe environment as well, then they are able to convey their problem and so on. And their peer actually very useful. So if you connect their peer into the service as well, the one you already provide service to them and connect them and have good relationship, they can be a good resource, because they would understand how to approach their friends. And we prove that peer-based education, actually, you can convey a good message to their friend and change their behavior as well.
Thank you. Next. No? Ready to leave? Okay, those thank you so much, Dr. Apinun. Thank you.